Hey everyone, and welcome. Today we're diving into a really fascinating medical mystery. We're talking about a skin rash that is unbelievably chronically itchy. But here's the thing, it isn't really a skin problem at all. Nope, its true origins are hiding somewhere completely different, in your gut. So what's the connection? Well, let's find out. I mean, just think about it. What if you went to your doctor with this maddening itch on your elbows and your knees, something that's driving you crazy, only to be told that the real solution has nothing to do with creams, but everything to do with what you eat? For the rest of your life? Well, that's the reality for people with dermatitis herpetiformis, or DH, and that's the core question we're going to unpack today. All right, so to really get to the bottom of this, we're going to follow the clues through 5 key stages. First up, we'll talk about what the patient actually goes through. Then, we'll see how doctors become detectives to crack the clinical code. After that, we'll look at the one single test that nails the diagnosis, we'll reveal the surprising science linking the gut to the skin, and finally, we'll lay out the 2-part plan to treat it. Okay, so let's start right where the patient starts, with a rash that is, and I'm not exaggerating, simply unbearable. You really have to understand this experience to understand the disease itself. So here's the official textbook definition. A few key phrases really jump out. Intensely pruritic. That's just a fancy way of saying it's so itchy it can make you miserable. Chronic tells you this isn't going away on its own. But the most important part? It's the cutaneous manifestation of celiac disease. In plain English, that means it's literally celiac disease showing up on your skin. So what does it actually look like? Well, patients get these symmetrical clusters of little bumps and blisters. But the defining feature, the thing everyone talks about, is the itch. It's so severe it can feel like a deep burning, and get this, the itching can actually start before you even see a rash. And because of that constant gotta scratch it now feeling, a doctor will almost never see perfect little blisters. They've already been scratched into oblivion. So, this brings us to the detective work. How does a doctor start putting the pieces together? Spotting DH is all about collecting clues, from where the rash is on the body, all the way down to a person's genetics. Now, for anyone out there studying for board exams, you are going to want to remember this. The rash loves to pop up on what we call extensor surfaces, the outsides of your joints. And the easiest way to remember this is with a mnemonic, sac-o bumps. The bumps appear on the sacrum, the arms and scapula, that's your shoulder blades, the knees, and the buttocks. S-A-C-K, sac-o bumps. And here's another massive clue, genetics. This condition is not random at all. The genetic link is incredibly strong. Just look at this chart. A staggering 90% of patients with DH have a specific gene called HLA-DQ2. Most of the rest have a related one, HLA-DQ8. I mean, when you see a number like 90%, you know you're onto something big. And the clues just keep piling up. DH is part of an autoimmune family, so it often brings friends along. The most important one, obviously, is celiac disease. Pretty much 100% of patients have it. But here's the twist. Only about 20% of them actually have gut symptoms, like bloating or diarrhea. For the other 80%, the rash is their only major sign. The gut problem is silent. Okay, so you've gathered all the clinical clues. The distribution is right, the genetics are suggestive, but how do you prove it? This brings us to the definitive gold standard test that confirms the diagnosis, no questions asked. All right, this part is absolutely critical, so listen up. You actually need 2 skin biopsies, and where you take them from changes everything. For a standard look under the microscope, what we call histology, you biopsy an active blister. That shows you the inflammation. But for the real diagnostic test, called direct immunofluorescence, or DIF, you have to biopsy the normal-looking skin right next to a blister. So why the 2 different spots? Well, this right here is a classic examiner's pearl. It's a common board exam trap. The intense inflammation happening inside the blister actually destroys the very evidence you're looking for, these little antibody deposits called IgA. So if you take that DIF sample from the blister itself, the test will come back negative, and you'll miss the diagnosis. You've got to go for the normal-looking skin right next door. And what does that DIF test show when you do it right? This. This right here is the smoking gun. You see these speckled granular deposits of IgA antibodies all packed into the very tips of the dermal papillae. This finding is what we call pathogenomic, which means if you see this, it is Dermatitis Herpetiformis. End of story. Diagnosis confirmed. So now that we have the diagnosis locked in, let's explore the why. How on earth does eating something like bread or pasta lead to an intensely itchy rash on your skin? Well, the mechanism is this fascinating story of autoimmunity and mistaken identity. Okay, so it all boils down to a case of mistaken identity. It starts when someone with that genetic predisposition we talked about eats gluten. Their immune system in the gut freaks out and makes IgA antibodies against an enzyme there called tissue transglutaminase, or TTG. But here's the problem. Those antibodies get into the bloodstream, travel to the skin, and find an enzyme that looks really similar, epidermal transglutaminase, or ETG. The antibodies get confused and attack it too. They pile up, forming those IgA deposits we just saw, which then calls in a flood of inflammatory cells called neutrophils, and that is what causes the blisters and that maddening itch.
So, how do we treat it? Well, the management plan is really a two-pronged attack. You can think of it as having two different levers to pull. You need one strategy for quick, immediate relief, and another, much more important strategy to fix the root cause of the problem for good. And this table breaks down those two levers perfectly. On one side, you have a drug called dapsone. This is your symptom lever. It works incredibly fast. We're talking relief in 24 to 72 hours by telling those neutrophils to calm down. But it does nothing for the underlying problem in the gut. On the other side, you have the gluten-free diet. This is the root cause lever. It's slow. It can take months or even years for the skin to fully clear, but it's the only thing that actually removes the trigger, heals the gut, and super importantly, it reduces the long-term risk of getting lymphoma.
And this brings us to our final high-yield takeaway, another huge point for exams. Dapsone is fantastic. It's like a fire extinguisher that puts out the flames on the skin quickly and gives a patient their life back. But the lifelong, absolutely non-negotiable therapy is a strict gluten-free diet. It is the only thing that treats the actual disease.
Now, while dapsone works miracles for the itch, it's a powerful drug that you have to respect. It requires careful safety monitoring. Before anyone even starts it, they have to be screened for something called G6PD deficiency to prevent a really dangerous reaction. And then throughout treatment, doctors need to keep a close eye on blood counts and liver function to make sure everything is staying safe. But let's end the treatment part on some really good news. The long-term outlook for these patients is excellent. For people who stick to a strict gluten-free diet, the rash goes away, the gut heals, and after about 5 to 10 years, their increased risk of a specific type of lymphoma returns right back down to the same level as the general population. So compliance with the diet is truly curative. So we end here. The story of Dermatitis Herpetiformis is just such a powerful reminder that the body isn't a collection of separate parts. It's a deeply interconnected system. A problem that starts in one place can show up in a completely unexpected area. And it really leaves us with a final question to think about. What other diseases might be out there, hiding in plain sight, just waiting for us to connect the dots?